This is Group 13 coming to you live from Sim Room 4.
Okay, Josh, start us off.
My name is Josh. I'm a PA in this situation.
My name's Cecilia, and I'm a doctor.
My name is Catherine, and I'm playing the chaplain.
My name is Audrey, and I'm the social worker.
My name is Clarissa, and I'm admin. So, as administrator, I brought our medical team together here to discuss an ethical situation concerning a 29-year-old man currently being treated under our care. He is declining the plan of care, but we also want to make sure he receives the proper medical attention. As admin, we are here to discuss the 4 bioethical principles to develop a recommendation that suits the patient's needs, yet we are concerned in terms of justice that other patients in critical conditions are waiting for a bed.
Alright, so to start us off, I'm just going to present the case. We have a 29-year-old man with no significant past medical history presenting to the ED today, directly following a car accident. Little patient background, he presented with complaints of headache and constant right-sided chest pain. Our assessments upon imaging verify several broken ribs and a large right pneumothorax. Our recommendation would be to place a chest tube and admit this patient to inpatient care for continued management. Patient was compliant, got a full education of the treatment. However, he shortly, or after being educated, he became uncooperative and demands to be discharged immediately. Upon my assessment, the patient did receive all the knowledge and education on why he should be receiving this treatment and how it would help his well-being moving forward. So then I present to my supervising physician to get her further take on it.
So, based on what you said, by providing him all his options with treatment and the benefits of the treatment, we did our beneficence of making sure he knows what would be good for him in the situation. But the fact that he wants to leave, we would not be taking the non-maleficence, or it wouldn't be met, because we would be harming him by letting him leave the hospital. And that would be doing him severe harm, as he would probably die.
Right, so essentially it's the patient's decision, since we did inform him of the consequences of not receiving this treatment and also the benefits of if he were to move forward with it. However, it's tricky because the autonomy of the patient went from complying with the treatment and is now wanting to be discharged and not receive any health management.
Yeah.
So we're here today to kind of discuss how we should move forward, considering our admin and social worker and chaplain is involved with the case.
Yeah, that would be severely negligent. Does anybody know why he wants to leave?
Well, as the social worker, I think it's important to let him know of the resources, as we're unsure what's prompting him to decline. We haven't talked to him yet. Although the patient is denying care and has the autonomy to make his own decisions, I can inform him of risks for his family, provide him reassurance of resources for him in terms of maybe hospital costs, distance from his family, or other events that may be contributing to his denial of care. So it's important for us to let him know his options prior to discontinuing care.
I think that's a good idea.
Yes, I agree. And as the chaplain, you know that my role is to make sure the patient's autonomy, especially with his religious beliefs, are maintained. I see in the chart that the patient is of Jehovah's Witness belief, and I am wondering if the patient is maybe concerned that this type of procedure could lead to the possibility of a blood transfusion, which goes against his religious beliefs. So because of this, I understand why the patient is concerned and wants to discontinue care. I also think that if we speak to him to clarify the specifics of the procedure and necessity, he may be more understanding.
Okay, definitely could see that.
The end.
So, so what is our plan basically with the chest tube?
I think our number one thing should be that we should definitely educate him on the risks of what's going to happen, like when he leaves the hospital, because that risk is probably death. And if he really does not want the procedure, I don't really think that we can strap him down and make him do it.
Yeah, the patient did present stable, and he was able to make decisions for himself and think about the treatments that were presented to him. So we can't sedate him, we can't strap him to the bed or anything. So I think above all, we got to go back on the patient's autonomy.
Right.
And really figure out what's best for allocating the resource of this hospital.
Sounds good.
I appreciate all you guys being here today.
Thank you.
You're welcome.